Good afternoon, everyone, and sorry for our slight technical delay. My name is Shannon Kupka. I'm a project manager working with the nursing home teams in New Mexico from Health Insight. I'd like to welcome you to our half-hour Hot Topics series. These webinars are designed to provide you great ideas on dementia care, behavioral health, and antipsychotic reduction strategies in a 30-minute time frame to accommodate your busy schedules. They are brought to you by the Qualis Health Insight teams from Idaho, Nevada, New Mexico, Oregon, Utah, and Washington, and sponsored by the New Mexico Healthcare Association and Qualis Health Insight. So we are very excited about today's presenter on dementia-related agitation. Dr. John Donaldson is a former assistant professor of consultation and liaison psychiatry at LSU Medical Center and regional medical director for the state of Louisiana. John had been involved with numerous studies and research projects for LSU in the state of Louisiana, and he has extensive knowledge in various aspects of mental health. He obtained his Doctor of Osteopathic Medicine from the University of North Texas Health Science Center in Fort Worth, Texas, and completed his psychiatric residency in general and child and adolescent psychiatry at USC LA County Medical Center in Los Angeles, California. He is currently in private practice, providing psychiatric treatment over the entire age spectrum, child through geriatric. I will now turn things over to Dr. Donaldson. Dr. Donaldson, you may get started.
So good morning or afternoon, depending where you are, and we'll go through this study that I put together. This is really about dementia-related agitation, but you have to start with differentiating between dementia and delirium. As you probably already know, most people with dementia at some time or another, say around 82% of these people, have some kind of behavioral agitation. And this agitation is usually due to when they're in a delirious state. So these two diagnoses are important, and it's good to differentiate the two. So that's what I'm going to try to do. Shannon tells me that I have another possibility of giving a second lecture. And I'm hoping in that second lecture, I can also talk about the treatment. So here we go. So major neurocognitive disorder is the new term for dementia in the DSM-5. So dementia is now called major neurocognitive disorder, and that is opposed to a minor neurocognitive disorder, which dementia is not. So what you see with dementia is a decline, or major neurocognitive disorder, is a decline in mental ability severe enough to interfere with independence and daily life. This replaces the term dementia. So remember that if they use that term, you know what they're talking about. All right. So dementia is a very interesting word. It's Latin, made of two parts, D, which means without, and ment or mind, and it was used for mad or insane. So people in ancient Greece that were diagnosed with dementia were called mad or insane. The introduction of the neurocognitive disorder term attempts to get rid of that stigma that's associated with dementia. Whether it's going to be successful, I don't know, but anyway, there we go. All right, so the disease itself of dementia or neurocognitive disorder is really a group of symptoms. It's not just one particular disorder. And in a minute, I'm going to show you a Venn diagram, a pie, if you will, with different slices indicating what areas of the pie or percentages of dementia correspond to the different diagnoses. So neurocognitive disorder is a broad term that can be defined as a condition involving impairments in thinking, remembering, and reasoning which affect a person's function and safety. And that's really the definition of dementia neurocognitive disorder. The main fundamental part of that impairment is really memory. Okay, so this is, again, a Venn diagram showing the different types of dementia. So the blue, the 65%, is Alzheimer's disease, which commonly or frequently is called Alzheimer's disease. Then you get, if you can see, this orange version is AD and vascular. The AD stands for Alzheimer's dementia. And so the combination of a vascular problem such as a minor stroke or a larger stroke plus Alzheimer's disease is about 10%. In fact, there's some studies to suggest that when you look at the brains of people with Alzheimer's disease in autopsy, you'll find that they have both vascular, little tiny strokes, little pinpoint strokes, if you will, and the Alzheimer's disease pathology as well. So it seems, for most people anyway, that they need to have both of those things together to really produce an Alzheimer's picture. So whenever you see someone diagnosed with Alzheimer's disease, they probably also have a little tiny bit of vascular going on at the same time. Then there's Lewy body dementia, which is now called dementia with Lewy bodies, but it's really on the continuum with Parkinson's disease. So you can put Parkinson's disease dementia in there and Lewy body, and probably it's all the same disorder, just different variations of the same thing. That's about 7%. So then you have Alzheimer's disease and Lewy body, that's about 5%. That's the golden piece of the pie here. And then vascular dementia by itself, that is post-stroke dementia, for example. Vascular being the new term for it, is about 5%. And then the other types of dementia are 8%. But remember, of all this pie, there's about 29 or more causes of dementia. So people get there many different ways. All right, excuse me. Now, neurodegenerative disorders result in progressive and irrevocable loss of neurons and brain function. Currently, there are no cures for any of these types of disorders, and they include Alzheimer's disease, frontotemporal disorders, Lewy body dementia, and other types of progressive brain disease, which include cognitive impairments and dementias because of vascular problems, and then mixed dementia is a combination of two or more types of dementia, as we showed in the Venn diagram. Other conditions that cause dementia, like symptoms, can be even reversed with treatment. For example, normal pressure hydrocephalus, if that is treated, then many times people return right back to normal. There's also that disorder, there's also really just a buildup of cerebral spinal fluid. So it's really a kind of a misnomer because it's more than normal pressure. It's actually increased pressure. But I've seen people that have had treatment and they've resolved their delirium or dementia that people thought within 2 hours. It's amazing. Okay. So in addition to certain medical conditions that can cause serious memory problems, they are things that are considered psychological, for example, emotional problems, stress, anxiety, depression, those kind of things. But then other things can also do it. So certain medications, in fact, I would suggest that if you have a patient and your care that is having some kind of difficulty, agitation, or change in behavior, that you want to look at the medications the person is on. That's probably the #1 thing to look at. The second thing is to look at any kind of infections, most commonly urinary tract infection, and that's easy to look for. You can actually even dipstick the urine and get an idea about what might be happening. There are other things. If your patient happens to get into alcohol, there could be some kind of brain clots, there could be head injury from a fall. You can have thyroid, kidney, or liver problems. You can have even constipation can cause this. So those are the things that you kind of look for. So doctors have identified many other conditions that cause dementia or dementia-like symptoms, and they include, agarphilic grain disease, which is a common late onset degenerative disorder that's usually seen in people that are in their hundreds or older. There's Creutzfeldt-Jakob disease, which has to do with, it's a prion. There's Huntington disease, which is inherited progressive brain disease. Of course, there's traumatic brain disease. And then there's HIV-associated dementia. All right, so when people talk about the hippocampus, that's a part of the brain underneath the shelf of the brain. And it is named because its shape is very much like a seahorse. If you can see in these two pictures. Can you guys see my pointer? Hello? Anyway,
Yes.
Okay, good. So if you can see here, this beak looks very much like the beak on this seahorse. And so hippocampus really means horse of the sea, so seahorse. All right. Now, it's important, very important, to distinguish between treatable conditions and the dementia itself. And so what is a treatable condition? Well, that's delirium. So anytime you have a patient that has a change in behavior, you need to always assume it's delirium, okay? And the other thing to remember always is the more demented a person is, the more neurocognitive, if it's more major than just major neurocognitive disorder, they are even at increased risk for developing delirium. So that's the first thing to look at. And that's really something you consider as a medical emergency, because it could be a whole lot of different things, including easy things such as a urinary tract infection, or very bad things like cardiac decompensation. Okay, the risk, again, of delirium increases proportional to the severity of the premorbid cognitive impairment, which is just saying the worse the delirium, the worse the dementia, the more likely they're going to have delirium at some point. Now, there is a test that people use called the confusion assessment method, and there are 4 key features it looks for: acute onset of change, and then fluctuation of that change, the inability for attention or inattention, disorganized thinking, and an altered level of consciousness. So if you see one of those 4 things, or all 4 things, then you need to think about this being delirium. Okay. Now, there are 2 types of delirium, basically. There's acute and subacute. Acute being it happens all of a sudden, and subacute means it's been happening for a while, off and on. What you see is disorganized thinking right away. They become disoriented. They don't know where they are. The onset is in hours, not days or years or months. The fluctuating course that they talk about is disturbance of consciousness. So they come in and out of being able to focus their attention. And then, of course, inattention or trouble concentrating. Now, one of the things that you'll see with delirium is autonomic instability. And that's just a fancy way of saying the vegetative signs of presentation. So we're talking about sweating, tachycardia or rapid heart rate, tachypnea or fast breathing, and BP fluctuations or blood pressure changes. Now, there are subtypes of delirium. There's the hyperactive type, which is a type that usually gets seen and treated. And what you see with that, and that's about 25% of cases, so 1/5 of the cases you'll see. So they're really excitement, impulsivity, and combativeness. They're also the people that are most likely to fall because they get up and move around. And again, these are the people that are also most likely to receive sedatives, and that also puts them at risk for falling down. One of the things I should add right at this point is that they've done several different great studies looking at different types of treatments for this delirium, this hyperactive type. And so far, none of the antipsychotics seem to have made any difference at all. In fact, may make them slightly worse. But what is the thing that we usually run to first? We usually either use benzodiazepine like Ativan, or we'll try something like Seroquel or something to sedate them. Now, the sedating effect may make them less agitated, but it sure won't help their delirium. And it doesn't help their length, of course, of delirium, nor does it help their final outcome. All right. So most of these hyperactive people usually receive psychiatric referrals, and that's usually the people that I see. This syndrome, really, of the hyperactive subtype, you see disorientation, delusions, agitations, hallucinations, and you need to look at their profile of medications and look to see what their anticholinergic medication profile is. Now, the anticholinergic receptors that these medications may bind to, or I'm sorry, the cholinergic receptors they bind to, they block them. That's why they're called anticholinergic. And there are many, many medications that are high on that list. And 3 or more of these, for example, can really make a huge difference. And so just by withdrawing some of those medications can sometimes really help. So the other thing you want to look for is alcohol in case they're using alcohol, or benzodiazepine intoxicants. So if they're using Ativan or Valium or Xanax. I must tell you, whenever I was a medical student, there must be hundreds of consults we got of people that had been taken off their Xanax, for example, by the surgical team. They were replacing a hip or something, and they didn't realize that these people were addicted to Xanax, and they would come unglued, and we'd have to come see them and then slowly reintroduce benzodiazepines. Okay, so are there any questions at this point? Anybody? Can you talk to me?
So if you have questions, I would say for sake of keeping us on time, go ahead and enter those into chat. And as you finish up, Dr. Donaldson, we'll do all those at the very end.
Okay, perfect. All right. So the other subtype is hypoactive subtype of delirium. And with that, you usually see immobility, withdrawn, posturing, and mutism. So people, for example, that were normally active and moving around may become very slowed down, may withdraw completely, and may not say anything. These people are usually sicker on admission to, say, hospitals. They usually have a longer length of stay in the hospital, and they're more likely to develop pressure sores because they don't move, and they can get hospital-acquired infections as well. They have a higher risk of mortality than the other group, that is the hyperactive group. There's more lethargy and somnolence, and then slowness of thinking that we call bradycrania. And they have longer lengths of stay in the hospital. They're usually due, though, to metabolic reasons. So CBC might be very helpful in this particular case, or a complete metabolic panel. Then you have the subtype of mixed, which are both hypoactive and hyperactive deliriums. Again, combination of the two types. So that's really the way to look at your delirium patients. Again, if you see somebody that's kind of the hypoactive becomes more withdrawn, then you need to think of metabolic reasons. If you see a more hyperactive type, then you need to think of someone who's probably medication related or infection related, for example. However, it's good to consider both, because mixed is 42 to 58%. All right. So predisposing factors to delirium. So cardiac output decrease. For example, this one study I read, people that are greater than 85 is the most common presenting sign after myocardial infarction. What you see is this mental status change. So it makes a huge difference. The other thing to look at is if you have a patient who has a big water weight gain, then you need to think about there's something decompensating their cardiac function. So again, if someone gains a lot of weight really fast, worry about their cardiac status. Then you have to worry about infections, so bacteria, which is bacteria in the urine or UTI, meningitis, even syphilis can happen in older populations. Urinary retention can sometimes cause it, so if it's possible in your facility, get a bladder ultrasound to see if they're retaining urine. And remember that if they already have dementia, 22 to 89% develop delirium. It's very, very common. And the reason for that is probably twofold. First, they are in a situation where they can't really, if they have dementia, they can't really ask for help. So they may be getting ill and not able to express that to somebody else. But the other thing is that with dementia, you really have a capacity decrease. That is they are very easily thrown into a delirious state because they don't have much capacity, much leeway, much ability to absorb stressors. And so they fall into the delirium very easily. Whereas people who don't have dementia can usually take a lot of these slings and arrows and not have the clinical case of delirium. All right. So potentially reversible deliriums, constipation, fractures, endocrine things like thyroid or parathyroid or diabetes insipidus, which has to do with water. Again, like we talked about, normal pressure hydrocephalus. There's nutritional disease like malnutrition, B12, thiamine, folate. Again, those are usually people that come from the outside into your facilities, not people in your facilities. Kidney or liver disease, anemias. And here's the tragic thing. You look at all those things, or you correct all those things, fewer than 13% of people who have delirium of whatever cause end up going back to where they were before, to their baseline level. So even though you can cure these things, there's something about the delirium that eats away, chips away, if you will, at their mental capacity. And so the delirium gets a little slightly worse. In one study, for example, after someone developed delirium in the hospital, 53% had deficits at 6 months. So it's not an uncommon thing to see someone slowly, gradually decrease their abilities after they have this. So again, remember, treatment does not mean return to normal, and treatable is a more appropriate term, but usually not curable, because you can't cure it in most situations. Okay, so Dr. Donaldson may be excused. My brain is full. Thank you very much.
And thank you, Dr. Donaldson. My brain is in fact full. So we had one question that started out. I'm going to give everybody a couple seconds to kind of formulate any additional questions you might have from the information. Okay. And we'd also like to hear if there's an idea or practice that you'll take away from today's session. We'd love to hear that too. So we did have a question on any medication suggestions for hyperactive delirium.
That's a very good question. So I would tell you that sometimes if you can make sure that the patient is not going to fall, then you can use things like Seroquel. Even though the studies don't really back it up, I would suggest that the sedation is sometimes very helpful. You can also use benzodiazepines, but you have to be very careful because benzodiazepines are not metabolized well at all in older people, even things like Ativan or oxazepam, which really require very little liver metabolism. You want to look at also their liver function, because that will affect how long the medication stays in their body, especially benzodiazepines. So those are the kind of two of the things to look at. The other thing though is always look to see what has been added and if there are any medications that are highly anticholinergic. There are lists. I could bore you with huge lists of medications that have anticholinergic properties, but you can always look them up. It's very easy now with your smartphone. Just dictate the name of the phone into Google. The name of the medication into Google on your phone, and you will be able to come up very quickly with its anticholinergic rating, and then you can see whether or not you think that might be causing this difficulty. Does that answer your question?
I think it probably does, and okay. While we're going, I'll see if, Esty says, yes, thank you. Donna asks, is there a screening tool that can be used in the nursing home to help prompt screening for delirium?
Yeah, the CAM test, I don't have time to go into that completely, but if you look at that test, it's pretty easy to understand. So again, take your smartphone, Google CAM test for delirium, and that will help you kind of determine what to do. There's all kinds of different scales besides that one, but that's one of my favorite ones. Great. So that's what I would say probably is the best.
Wonderful. Oh, okay. And as Steve mentions, the CAM is part of the MDS, so that's great. Thank you for mentioning that.
Sure.
Okay. Do we have any other questions or comments that folks had? Want to kind of get you out on time, but also recognizing we had some technical difficulties that started a minute or two late. So I'm going to give you about 10 seconds to think on that. While I'm thinking on that, I wanted to let folks know that we did post in our chat where you can find our previous hot topics, and that's also the same link where you'd be able to access this presentation. We usually post it a couple of weeks following this event. So, all right, I'm not seeing any burning questions. I'll give you another couple of seconds to come up with this. And Sandra said, thank you for making this information accessible. You're very welcome. We're happy to do this. And I also had a comment from Bonnie saying, thank you for a wonderful presentation. Another question. Can those with vitamin deficiency get back to normal after a vitamin supplement?
Yeah, very good question. Most generally they can. Sometimes, perhaps not, but I would definitely try it. And I always have my patients, and I don't care how old they are or what we think their longevity is going to be, to take 4 different vitamins. So those 4 vitamins are based on, well, way too much scientific data to present it here, but let me just go forward with it. So the first one is a multivitamin. Now, multivitamins are difficult in some people because usually multivitamins nowadays are gigantic and they're more like suppositories than oral. So it's difficult. You can sometimes grind those up, but they're usually nasty tasting. So one of the tricks is if they can chew, then you can use the Flintstones Complete vitamin that has everything they actually need. If they can't chew, you can grind it up and put it into food if you need to. So that's a multivitamin. So that's number 1. Number 2, I think they need a B complex vitamin. B complex are basically the 100% of the essential B vitamins that one needs per day. So of those, there are 8, and you can get something like from different brands, Costco, you name it. But you want to make sure that you look on the ingredients and make sure it's 100% at least of each one of the B vitamins. Then you also need an omega-3 fatty acid. And that's important because it looks like the omega-3 fatty acids are exquisitely important in the absorption and distribution in the brain of these B vitamins where you want them to go. So without an adequate level of the omega-3 fatty acids, the B vitamins will not be absorbed properly. So that's important. So again, a multivitamin, a B complex vitamin, and then omega-3 fatty acids. Finally, there is great research to show that vitamin D3 is helpful for lots of things, including bones, but a lot of emotional conditions and so on seem to be helped with vitamin D3, along with many of the enzymes that are used for metabolism. Now, the interesting thing is that anything above the 37th parallel, any place above the 37th parallel, during the winter months, the sun does not have enough energy in its rays to convert the cholesterol molecule in your skin, which is then changed into the free vitamin D, and then the liver changes it some more, and then the kidney to make a vitamin D3. So what I'm trying to say is that if you're at altitudes, or I'm sorry, latitudes, or not latitudes, what am I saying? At longitudes, I'm sorry, no, latitudes is correct. Losing my mind. Latitudes above the 37th parallel, and that, by the way, is Las Vegas. Believe it or not, Las Vegas is a few degrees above 37th parallel. Anything above that in the winter months, they need vitamin D3. So how much vitamin D3? Well, that's up for debate, but I can tell you this. Here where I live in Monterey, California, we're at 36 hours and 36 minutes, so not quite 37, but we have lots of cloud cover. And vitamin D3 levels, or OH vitamin D levels in my patients' bloods, and many of the physicians around here, is low. And the reason is because they just don't get enough sun. All right, so what do? Well, then you give, I would say, 5,000 international units, which is really kind of a small capsule, every day. And you do that all through the winter months at least. That is starting in September all the way through the end of March. However, if your patient doesn't leave the facility, stays inside, or you're in a position or a location where there's lots and lots of cloud cover, then what you have to do is you really need to provide that vitamin properly all year long. of my patients that are in facilities that are on the 5,000 international units all day long, or all year long, or what have you, those people have usually a level about 95, and upper limit of normal in most laboratories is 100. So you're right there at the higher end of normal. So that would be more protective. So those are things that I would suggest that you need. So again, to recant, multivitamin, a fish oil, a B complex vitamin, and a vitamin D3. Those are the 4 things that you need. And that's, I would say, for no matter what age they are or whatever you think their longevity is going to be, it's going to make things usually better. All right. That's my spiel on the vitamins.
So we had one final question on Haldol usage with folks with dementia. So if you want to comment on that.
I would love to. So Haldol was originally developed for IV use. And I would suggest the best way to use Haldol is IV. So the reason for that is basically that you can avoid a lot of the side effects, a lot of the akathisia, that is the sense of restlessness, the acute dystonic reactions and so on that Haldol can produce. That being said, there was a study done where they took, I think it was 291 patients, and these were patients with delirium, and they treated them with IV Haldol. That compared to a group who didn't receive it. The group that didn't receive it did better. So I would suggest it does not work, unfortunately. IV Haldol is really a great medication, but IV Haldol, and especially oral Haldol, does not work.
Okay. And for those of you who might be looking for non-pharmacological approaches, we certainly have a lot of resources on that and would be happy to share that. We had one question also about advanced dementia. Is there a need to continue Aricept? Can you comment on that in like 10 seconds or less? Sorry.
Yes, I can. Sorry about that. I would suggest this, that I've seen several patients that when you stop, that have really advanced dementia, if you stop the Aricept, they really have a horrible course. So I would say that it's really not that expensive anymore, and I don't see any reason to stop it. Unless you have another agent that you think is also hitting those receptors, then you don't need it anymore.
Okay, thank you very much. I appreciate that. And I want to get everybody, I want to get y'all back to your Friday. So just a couple of tie-up comments, which is, again, the presentation is going to be posted to our website in a few weeks, and I encourage all of you to check out our posted webinars there on our nursing home library. The link is in chat. Please share this with any of your colleagues who couldn't attend, or use it to in-service your staff. For continuing ed credits, again, New Mexico teams, please enter your name and email in chat. And those of you out of state, we will be sending a certificate to your state lead that they can provide you to show attendance for today. And please join us on April 26th for our next hot topic on trauma-informed care. So I'd like to say thank you once again to our presenter, Dr. John Donaldson, and our brains are very, very full now after this, and we'd love to have you back. So thank you for joining us today, and thanks to all of you for your time and for joining us for Hot Topics. This is the conclusion of our webinar. Have a great weekend.
Thank you very much.